questions I've just been asked is, what are the best ingredients to use if you have rosacea? Well, rosacea presents in a number of different ways. One of the ways it can present is just in the stinging and the burning of the skin with repeated flaring and flushing, and actually not much to see in between the times of these flushes of redness. For some people, it's often related to ultraviolet light exposure, and you might have that background ruddiness or redness with telangiectasia, visible blood vessels, and just a sensitivity to the skin. And then for other people, it might present with lumps and bumps that might look a little bit like acne, but it is different and it doesn't have any blackheads or whiteheads and tends to present in the mid part of the face. Other people, it can just present as eye disease. And then for some people, more rarely, it can present as thickening of the skin, and that's called phymatous change. So rosacea can present in a number of different ways, and actually that's why it's probably quite an undiagnosed condition in many cases, and some people will just think that the irritation or sensitivity that they experience is just their normal skin and will never actually see a dermatologist to try and get some help for. But actually it's really important to try and get that help, because it can then prevent the skin from going on and developing worse stages of rosacea. And also, when your skin feels comfortable, then you typically feel comfortable. So some of the ingredients that we might consider for treating rosacea. The first thing really is actually not about ingredients, but it's about looking at your lifestyle. So it's keeping a strong diary, and by that I mean a diary that will last probably around about 3 months, where you're keeping an idea of when you get a flare of your rosacea, when you get the redness or an increase in pain or sensation changes on the skin, and things that you have done. So whether that's related to being in sunshine, whether it's been related to doing exercise, if it's related to being in a sauna, eating spicy foods, drinking hot drinks, and putting certain products on your skin. And it's keeping that really close diary so that you can work out if there's certain triggers that are relevant to you. So that would be my number one thing. No ingredients, just looking at your lifestyle. Second of all is really simplifying what you're putting on your skin. So taking away anything at all that is too harsh on the skin or might irritate it, and just going back to a very, very simple cleanser, a very simple moisturizer, and really, really importantly, because it's involved in the pathogenesis of rosacea, is to try and find an SPF that you really like just for you. And if you don't find it the first time, I promise there will be one that you will find. My patients who have very sensitive skin and rosacea, so skin sizes 1, 3, 5 and 6, often like products like the Altruist face fluid, or La Roche-Posay Anti-Helios Comfort, or the Beauty of Joessence Sun Relief. You know, these are all products that are really quite nice for those skin sizes or people who have rosacea. Then the next thing is to think about the active ingredients that you might want to put on the skin that will actually treat the rosacea. And we have gold standard ingredients that are used in medicine. And it, like I said, depends on the type of rosacea that you have. So number 1, topical azelaic acid at 15%, topical ivermectin at 1%, and topical metronidazole are all considered first line ingredients to be used to treat rosacea. Topical metronidazole is available at 0.75% and at 1%, and there's not much different really between the two of them. And they have been shown in a randomized control trial to be superior to placebo, in other words, to something that's we know is not likely to do much in treating inflammatory papules and pustules of rosacea. And it's generally really well tolerated by people. It doesn't really tend to sting or itch. But of the 3 topical ingredients, it would probably be the one that I would have at the very bottom of those 3 agents, and that's not what I would tend to prescribe straight off, because I don't see the response quite the same as you would do with azelaic acid or with ivermectin. Azelaic acid. So azelaic acid is available in 15% and in 20% strengths, and both of them are suitable for treatment in rosacea, and it can also be used once a day or twice a day. I typically use 15% for my patients, and I typically just recommend once a day. There are multiple studies now to show that there's little difference whether you're putting it on once a day or twice a day, and for that very reason, most of my patients are super busy and have, I want to get a skincare routine that's going to work for them for forever, really. And so I recommend just putting it on once a day. It's been shown to be superior to metronidazole, which is why I tend to go for that as my first line ingredient over the metronidazole treatment. One caveat to the azelaic acid is in about a third of patients, they do find it a little bit stingy whenever they first start using it. And the stinginess is to be expected and is actually very normal. What you shouldn't do is rub it off straight away, because that will actually aggravate it and make it more uncomfortable and persist longer. But the stinginess is something that gradually with time and after each application it gets less and less. So I would certainly still pick azelaic acid, and it's because it's been shown to be superior in those inflammatory papules as well. And lastly, 1% ivermectin. This is probably one of my most favourite ingredients for treating rosacea, particularly whenever it comes to the papular pustular type of rosacea. And the reason we use this is not only because it's an anti-mite, in other words, this is the medicine that kills the Demodex mites that live in the follicle, but also it does have anti-inflammatory effects as well. So both of these things are working whenever it comes to rosacea. It has been shown to be superior in its mode of action compared with metronidazole, so another reason why you would prefer to use that over just metronidazole. And it's also been shown to induce a much longer remission. So we think about it, we have got topical ivermectin, topical azelaic acid, and topical metronidazole. And typically, if I'm just hoping to treat somebody with rosacea with topical treatment alone, I will pick 2 of those ingredients and usually use azelaic acid and 1% ivermectin together. Another ingredient that I will often use for treating rosacea is sulfacetamide sulfur. This is a sulfur agent. It's a bit stinky, which is why not a lot of people like it, and it doesn't have quite the evidence of the other 3 ingredients that we talked about, but actually some patients do respond to it incredibly well. It can be available in a 10% cream or a 5% cream, and often it's available just over the counter. There's some people who are more sensitive to it than others, and some people are more sensitive to the smell than others. So it certainly is a good ingredient to use, but it doesn't have the evidence of the 3 I've just talked about. Another very useful ingredient for treating rosacea is tretinoin, isotretinoin or adapalene. These are retinoids, and we know that they can have a really positive effect on the skin in terms of them being anti-inflammatory, and they're also very reparative to the extracellular matrix proteins, which is often a problem in rosacea. So there are studies to show that actually it is superior to something like metronidazole gel, which I also talked about, in treating inflammatory lesions. Now, they can often be a little bit more tricky to start, and the base is very, very important, and it shouldn't really be just thinking about this like an acne, because that could actually irritate the skin further of rosacea. So although retinoids can be used, we have to think carefully about how we deliver them to the skin. Equally, if you're just somebody who has a flushing, flaring erythema of rosacea, actually tretinoin at 0.05%, if used in the right base, has been shown in an Australian study to reduce the baseline erythema, and it's probably to do with that reparative UV previous damage that has been done. That's what the postulation is. So it's another really good ingredient, but has to be delivered carefully. The first thing I would suggest if you want to try and take control of your skin is to understand, do you have any specific triggers or flares of your rosacea? And is there something that you could quite conveniently just put out of your day-to-day routine that would actually then benefit your skin from the long term? I mean, it also might be something that you're not willing to put out of your routine, and therefore you can think of ways to modify what you do so you can continue to do the thing that you like, but your skin might not suffer. So I'll give an example of that. If you keep a skincare diary, the idea behind this is looking for the times that you have your flares. So whenever you have a flare for you, whether that's an increase in a lot of the spots, or it's an increase in pain, or it's an increase in sensation changes within the skin, or that flushy, flary stinginess, either way, whatever the flare is, it's important to note what the flare is like, what time of day it was, and the kind of preceding things that happened before it. And I'm not meaning just immediately before, I'm talking about within the hour before that happened. So the kind of typical things that would cause it are if there's been an exposure to an extreme of temperature, so whether you've then gone somewhere warm or even like opened an oven door and the heat of that has, hit off the skin, or walking through the very cold Marks and Spencer's aisles, stuff like that. This change in the actual temperature. And if you've had sun exposure, and that can even be sun exposure sitting by a lovely window like this, but where the sun has been hitting off the skin and causing some heat change, but also ultraviolet difference change as well. Then a record of whether you've had hot beverages or not. So, teas, coffees, because interestingly, the caffeine is probably quite good for rosacea, but the hot part of it is not. So that's like an iced chai latte would be fine, but the hot component of it might not be. So keep an eye on that. Spicy foods, alcohol, exercise. And exercise is one of these ones that's non-negotiable. We need to exercise, so there's lots of different tips and tricks that you can do if you like to go to the gym or rowing machines or whatever to try and prevent the flares and flushes that you might get. Also important to keep a note of the topical products that you put on the skin. For some people, certain ingredients will set the skin off, like phenoxyethanol or niacinamide. And for others, it's the whole product itself rather than the individual ingredients. Keeping a note of those kind of psychological feelings. So if you're stressed or anxious or scared or feeling embarrassed, does that trigger it off? And then certain drugs can trigger it. So if you're taking certain vasodilators, blood pressure medicines, medicines for your kidneys, nicotinic acid. And then also if you're somebody who has been using something harsher on the skin, so if you've used a product like a face mask that you've not perhaps used before, and then also key, and especially for this time of year, where you've maybe gone from a nice warm house environment to the cold outside where the air is dry and it's cold. And if you're somebody who already has a weaker skin barrier and reduction in sebum on the skin, then very quickly your skin can become at the mercy of the dryness and the irritation causing flares. So that's what I mean by keeping a diary of what these flares are. And it's not just a one-off thing, because you have to have it happen and then happen again on repeat. So just because it happens once doesn't mean that was the cause of the flare. It actually might have been something else at the time. So that's why a diary over a period of time is important. Once we get past that 3-month period of time, you're not going to do it again, because then it would just drive you mad constantly having to do it. But to do it properly the first time is really important. Now, it's also important to know that alongside your inside organs, they can sometimes have an effect on whether you have rosacea or not. And it is important to try and ensure that none of those things are relevant to you. So there is a strong link between rosacea and inflammatory bowel disease. And there are these moderate associations between rosacea and celiac disease, as well as irritable bowel syndrome. And there is also some studies saying yes and some studies saying no of a correlation between Helicobacter pylori disease, so kind of related to gastroesophageal reflux. So if you're somebody who does have bowel symptoms, any GI symptoms really, then that for some people is relevant history relating to your rosacea, and probably if those other things were under control better, then also your skin disease would be. So it's important to think that if you do have that coexisting, then that will be a good thing to explore further with your doctor. There are also certain components of metabolic syndrome that are related to rosacea, and so for some people who have dyslipidemia or coronary artery disease or high blood pressure, then that has been shown also to be correlated with rosacea, as well as this huge big study that was done by the Nurses Health Study, and they showed that obesity is actually a risk factor for rosacea in females, not in males, in females as well. So that is something to consider, that modification of those, which is obviously would be very good for your overall health, can actually have a positive impact on your rosacea. And then there are certain autoimmune diseases that whenever you've got, as we talked about the immunity before, where you've got this increase in just general inflammation as a consequence of your immune system being switched on a bit more quickly, then that too can affect your rosacea. Rosacea has been associated with neuropsychiatric disorders, so if with increases in anxiety and depression, there's also an increase in people who have rosacea. There was some thought that for people who have this neurogenic response to rosacea, so the flushing and the flaring that can happen without much in the change of the skin, might be related to migraines, but that actually hasn't been, there's no proven link established with that, it's just a theory. So the skincare of rosacea is very important. And I'm going to talk briefly about the commonest presentations, because to go into the nuances of some of the rarer forms of rosacea would be too time consuming, although I've got the time. So let's think about the common skincare routine. So the first thing really is the skin cleansing, and you really do need to have gentle skin cleansing. I typically recommend very, very bland cleansers. They should be non-foaming cleansers. They're normally all just cream cleansers. And this cleansing step should not be omitted. So some people will come and say, my skin's so sensitive, I can only use water. Well, that's not enough, because actually the irritants that might otherwise be on the skin, those Demodex mites, those dead skin cells, the excess sebum for many people, it has to come off, because otherwise that is going to set off this inflammatory thing that we talked about, and then you're in this vicious cycle. So skin cleansing is actually non-negotiable. It has to be done at least once a day. I'd probably recommend doing it in the evening, and I recommend using a gentle cream cleanser. I like things like the Cetaphil Gentle Cleanser. I like the Toleriane Cleanser, the Aven Gentle Cleansers. These cleansers are fantastic cleansers, and you need a cream cleanser with some mildly warm water. I recommend people to use either a cotton face cloth gently to rub the skin, or the fingers. And you would put your cream cleanser on, you'd rub it in all of the areas that you need, and then using warm-ish but not too hot water, just let's say lukewarm water, to wash it all off, and then pat the skin dry. Don't rub the skin dry. If you're somebody who has the more, we would call it a skin size 1 or a skin size 3, where your skin is an oilier, sebaceous-y type of a rosacea, well then actually you might benefit from getting additional oil off the skin, and you might want to use an oil cleanser as well. So you would then oil and then you would use your gentle cream cleanser. The next key thing to think about is moisturizing, because typically the skin barrier is the thing that's a little bit out of kilter. And I would say to you, you got to think of it almost like putting on a nice little cushion around the skin, like a nice blanket. So it's to be as gentle as possible. Your skin moisturizer, it needs to be the moisturizer. It has to have the humectants in it to draw the moisture in, and it has to have the emollients in it to moisturize it. So the reason for that is that you try and avoid anything with too many other ingredients in them, because they are the things that actually then might irritate your skin. So you don't need a moisturizer that has retinol in it, or a moisturizer with additional antioxidants, because it's not going to do the trick. It has to be nice, gentle moisturizing, and that helps to repair but also maintain this cutaneous barrier function, and that's incredibly useful. So there's multiple studies now, particularly split face studies, to show how beneficial the effective is of moisturizing, and typically it would really need to be done twice a day to get the best outcomes from it, or else having very good moisturizer that you're using that will try and last the day. But typically it's a twice a day thing that would need to be done, and you see then improvements in dryness and roughness, and the skin barrier can just behave in a much more stable way. So it's also very important to probably avoid a certain number of ingredients, and I would suggest that it's avoiding topical ingredients that you already know are going to irritate your skin, but it's avoiding quite astringent chemicals. So it's things like toners, best avoided. Any other astringents, chemical exfoliating agents, so things like alpha hydroxy acids, they are best avoided in somebody who has rosacea. And in addition, vitamin C can sometimes be very irritating, and particularly how it might be formulated for some people who have rosacea. I have rosacea and I use vitamin C daily, but I do understand that for some people it's a bit trickier to get used to. Normally, skincare products in the forms of creams are the things that are better tolerated than if they are in gels and thin lotions. And typically you're looking for something that's going to just continue to moisturize and nourish the skin rather than inflame and irritate it. Almost thinking about the skin barrier a bit like if you had a piece of chili on your fingers and you put the chili on your hand, or especially on the palm of your hand, you're not going to even know that the chili's there. But, and put that chili that you've cut on the inside part of your lip and you can certainly tell the chili is there. That's the difference between the skin barrier behaviour. And in people who have rosacea, they're more towards the mucosa type of behaviour than the palm of the hand. And then lastly, it's about finding the exact right sun protection for you. The sun protection is a non-negotiable element of your rosacea skincare plan. And it's difficult because you might find that certain skincare filters, sun protection filters you might put on the skin irritate the skin, and you might have tried tens of them in the past and they've just not worked. However, we know that both the radiant heat from the sun as well as the ultraviolet damage and the induced changes that occur as a consequence of ultraviolet damage do promote rosacea. So it is a really important step to get just right, and it also adds that lovely blanket or cushion that you have on your skin. It's worthwhile going through step by step some of these to see whether they're the right ones for you. I'm going to name 3 just now and you'll find them in the link below, but I would go for the Ultrist face fluid or even the Ultrist cream SPF 50. I'd also think about the La Roche-Posay, the Comfort, the anti-sting for the eyes. And I also like the Beauty of Jouissance, which is the sun relief. These are the products that my patients do typically respond best to if they have rosacea. Okay, what's our next step in treatment that we typically consider for rosacea? Well, let's first of all think of the rosacea that is the facial redness, the flushing, the skin sensitivity and the skin dryness. So these are more our skin sizes 5 and skin size 6 if it's gone on to form a rosacea. Well, the first approach to treatment is the non-pharmacological way, so what I've discussed already. So that's very useful for people who have very mild symptoms, and perhaps in keeping the diary you've been able to work out what your triggers are and therefore avoid them, or put modifications in place. So that would be our real first line interventions. Our second line interventions then fall along the lines of what we can then start to do to intervene, and sometimes that's using topical medicines and sometimes it's using energy-based treatments. Now, what I'll talk about first of all are the energy-based treatments. So these are laser and light-based therapies, and we use them extensively to treat vascular lesions. I first of all started using these about 15-20 years ago whenever we're treating birthmarks, particularly in children who have port wine stains, but also in adults at that time. As we learned more about lasers and they became more sophisticated, we were then able to use them in a much more nuanced way, and now we can use them to treat a multitude of conditions. But in this particular case, we are treating either the background redness, so this background erythema, or individual broken blood vessels, or individual areas of telangiectasia. And how it works essentially is that the light that is emitted from the laser, so a single wavelength of light or a broader wavelength of light in an intense pulsed light machine, either way the light energy is absorbed into the hemoglobin in the blood vessels in the skin, and that causes that blood vessel to heat up and to coagulate, in other words stick together so it's not there anymore. And that is the process of the light energy being converted to heat. Because the skin cells do not have the color associated with them, the light energy passes right through the cells and just goes to the target tissue. So typically the type of energy devices that we would use would be something called a pulsed dye laser, which is my preferred treatment usually, particularly for the broader erythema as well as individual lesions. We can also use a potassium titanyl phosphatase laser or a KTP laser it gets called, and both of these can be used like intermittently for each other. There's also other devices that we have that are suitable for more superficial lesions, like a ruby laser. Then in addition to that, there is then the energy-based device called an intense pulsed light machine, which isn't truly a laser, but it has certain cutoffs of energy, and that is very useful in a way because we can actually change the filters of which we use it to go deeper and then become more superficial, so you can target the vessels at different levels within the skin. It's difficult to say which device is better to use. There is more evidence for the pulsed dye laser compared to the KTP or the ruby, and there's a lot of evidence also for the IPL, so it really boils down to the IPL versus the PDL or the pulsed dye laser. But either way, the two therapies are similarly beneficial for both the facial erythema and telangiectasias. They're also very useful for somebody who intermittently flares, and they've been shown that with active regular treatment you can then reduce the flares that people will then experience in between. Moving on then to pharmacological therapy. Now, the pharmacological therapy is tricky because this is really related to whenever the flushing just occurs, and you've got your topical skincare that we've already discussed, and what I'm now trying to tell you is something that you can put on the skin that will reduce the flares of redness, or if you're somebody who's got a constant background erythema, it will take away that background erythema. So given we're in the UK and this is where I practice, I'll talk to you about the ones that are available here. The treatment to reduce down the redness that has a license for that is something called brimonidine. Topical brimonidine is used because it essentially constricts the blood vessels. So those blood vessels that are open and baggy and visible on the surface of the skin, and they make the skin appear red. Well, when you put brimonidine onto them, they shrink down and they become tight. And it gives the appearance of the skin no longer being red for that time. Now, it typically lasts for probably around about something like 10 to 12 hours, maybe a bit less, and then the colour comes back. That's where the problem is for some people, because when the colour comes back, it comes back with a vengeance for a few people, and it's called a rebound. If you're somebody who already has very sensitive skin and very sensitive to those subtle changes, well then actually you find it very uncomfortable. Now, it's reported to be something like about 5 to 10% of patients, I would say, that get this. My experience, however, is it really is much higher than that, and I would say probably about 1 in 4 people I would give this to would not like to continue to use it because of that rebound that they get. Now, the brimonidine has not been used on the papular pustular type of rosacea, so I can't, there's no comment as to say whether that works. I certainly wouldn't use it or treat it for that very reason. So brimonidine can be very, very helpful for some people, but I do always deliver it with this, as you can tell by the way I'm saying it here, this slight level of caution because of the rebound that can go alongside it. That said, for other people, it is a total game changer, and they just put it on so that they're going to get their rebound in the night when they're asleep, and then they don't really notice it, and it's kind of life changing for those people. So it's a really effective drug, but it's not for everyone. Another very effective ingredient to use if you're somebody who has the redness of rosacea is a topical retinoid, and in the form of retinoic acid. There's no point messing around with retinols or retinals or any of these things, because if you're going to use these, you need to have the very effective ingredient, and the studies were done on 0.025% retinoic acid or tretinoin and 0.05% tretinoin. That was actually shown to reduce and sustain the reduction of facial erythema. And it's probably to do with the reparative effect that it has on photo damage within the skin, and also stabilising the skin barrier and actually go in some way to improve the skin barrier. It's obviously very difficult and tricky for some people to start this ingredient, but nevertheless, if started in the right way, and certainly when we're formulating it, it's with all of these considerations to try and ensure that we can get that ingredient in so you can get the long-term benefit from using a retinoid. It's been shown to be very, very helpful. And then there are other treatments that are really off-license but can be very effective. One of my favourite off-license treatments for treating redness and flares and flushes of rosacea is to use micro depot injections of botulinum toxin. I find this incredibly helpful. It lasts about 4 months in patients, and they get a reduction in the flares. They also get a reduction actually in the seborrhea of the area if that's an issue for them. And in terms of the skin barrier, the sensitivity is improved. This is kind of expert advice. This does not have the evidence base to support it, although I would suspect in the future it will do, because more and more people are continuing to use that. Okay, so now onto the papular-pustular type of rosacea, or rosacea whenever you're getting the red lumps and bumps or the pussy lumps and bumps. And the first level of intervention is of course the diary and the modification to the skincare routine, but then what happens next is what we can apply topically to the skin. And the best evidence comes for one of 3 agents, either topical metronidazole gel, topical ivermectin, and topical azelaic acid. And these 3 have the most evidence behind them. In the order of which I would like to prescribe them to people would be, purely for the papular-pustular rosacea, I would go for 1% ivermectin, followed by the 15 to 20% azelaic acid, followed by metronidazole. That would be my top 3 order. But ideally, if I can, I will use azelaic acid and 1% ivermectin together, and it can both be applied once a day. So it's very easy for you to incorporate it as part of the skincare routine. So that's the typical way in which I would approach treating rosacea. Why do I do it like that? Well, in the randomized controlled trials that have been carried out, azelaic acid and 1% ivermectin are superior to metronidazole, and therefore because of that reason I'm going to try the 2 that I know that are going to be more effective first off. The advantage of metronidazole, however, is it's super well tolerated. People do really like to use it, and it doesn't have the stinginess that can sometimes go alongside the azelaic acid. But that said, the combination of azelaic acid and ivermectin would be preferred. There's also a randomized control trial looking at which of these agents, if it gets control of disease, can induce the longest remission, and the answer to that was 1% ivermectin. So 1% ivermectin, why do we use that? Well, it works as an anti-mite agent. In other words, it gobbles up and gets rid of those Demodex mites that live in our follicles. And when they're gone, it then means our body isn't having that immune response to it, or it's reduced in numbers, and therefore that is the theory behind its help in improving rosacea. It also has an additional benefit, and the additional benefit is that ivermectin itself is an anti-inflammatory, so applying this anti-inflammatory to the skin can also be helpful. I'm sure it has an additional benefit in that it's made up in the old Cetaphil cream kind of base, and it's a really, really lovely base. So that's typically what the Soolantra is made up in. So those are typically, they're the reasons why the 1% ivermectin is most effective. The next one is azelaic acid. It can be 15 or 20%, and most of the studies are at 15%, and the license that we hold in the UK is at 15% as a prescription-only medicine in the form of Finacea. I like to use it once a day because that just fits in much easier with patients' skincare routines, and therefore they're more likely to use it and more likely to continue to use it. And then lastly that is the metronidazole, and that's usually a twice a day regime, and sometimes people don't like how their makeup might look at whenever they put it on top of the gel afterwards. It can go a little bit crackety. So I'll tend to stick with the first 2, 1% ivermectin and 15% azelaic acid. These drugs do not work quickly, and in fact the skin can often be a bit worse before it gets better. You cannot rule it out and say the drug is not working until it gets to at least 8 weeks into the treatment. That's what the studies show. Benefit starts to appear at around about 8 weeks. Anything you see within 1 week is purely luck or a moisturising effect or something else. But it's really around 8 weeks where things start to work. And if things haven't worked by week 12, then you can say that that is a treatment failure. Anything before that, you're just guessing, and it's not accurate information for yourself. And you don't want to discount a medicine that actually might be very effective for you for the long term. If, however, at 12 weeks things have not improved to where you need them to be, well then you might need to have a tablet by mouth. When it comes to tablets by mouth for rosacea, one of the options that are first used are oral antibiotics. And these are from the group of the tetracyclines, and it can be in the form of limacycline, doxycycline, minocycline. And these are typically given in, shall we call them submicrobial doses? In other words, they're low doses, and they're really being used for their anti-inflammatory component as opposed to just the antimicrobial component. We actually use antibiotics in dermatology in an anti-inflammatory dose to treat lots of skin conditions. It can be very effective because they are anti-inflammatory as well as antimicrobial. So typically these are delivered in a lower dose than what you would take if you're normally treating a kind of infection. They're given for a set period of time, usually 3 months, to see if this can induce a response. And if it's enough to induce a response, well then some people have to be on intermittent courses of it. So taking it for 3 months, having a break, retaking it again in say 6 months or a year's time, and maintaining things with topical treatments in between. And the antibiotics are fairly straightforward and easy to take, and most people don't run into problems whilst using them. However, there's probably a little bit of caution to be said with skin types that are a bit more sensitive or might have melanocytes that are a little bit more easy to make pigment. So say for example you're a skin size 1, and that skin size 1 means that you have lots of active sebaceous glands, so you've got it's oilier, but you also have that oily type of rosacea, but also your melanocytes are stimulated fairly easily. Well, in a few people who are taking these tetracyclines, they can then develop hyperpigmentation as a consequence of taking them. So there is that little caveat of caution there. But that is a small kind of payoff really in order to get under control what is often very debilitating inflammatory disease. If, however, you are somebody who is then continuing to get lots of inflammation of the skin, lots of seborrhea, lots of rosacea, lots of these very inflammatory signs and symptoms, well, repeated courses of antibiotics are obviously not going to be appropriate for forever. And at that point, if you're somebody who's failed topical therapies and failed oral antibiotics, then oral isotretinoin or a high dose vitamin A is now considered part of our guidelines as to be the right treatment for you. Did I say high dose? I meant low dose. If I did say high dose, I didn't mean that. Low dose. Actually, it can be any dose, but probably low dose is the best. And certainly all my patients go on to a low dose of isotretinoin for a fairly longer period of time. Now, high quality data on this is pretty scarce, and the vast majority of it is related to expert opinion and smaller case studies. But this can be something that's pretty life-changing for somebody whose life has been dominated by this very severe facial skin condition. And there's also some evidence to show that in the reduction in seborrhea it will also help in that phymatous change. So in people who've gone on and had thickening and changes of the skin as well. When it comes to the exact dose to give, your dermatologist can discuss that with you. Like I say, I typically go for a low dose. There was a study carried out comparing 0.3 milligrams per kilogram to 0.5 milligrams per kilogram. 0.5 milligrams per kilogram is the typical starting dose if it's an acne type of rosacea, for example. And the 0.3 was superior when it came to treating rosacea because it reduced those inflammatory lesions by around about 90%. I mean, 90%. But it didn't have the same side effects or other dermatitis that was then triggered off by the isotretinoin. And other studies have actually brought this down to around about 0.2%, and again replicating the findings in that original study. So really probably somewhere around about 0.2 milligrams per kilogram until the inflammatory component is very well controlled, and then that could even be reduced again to 0.1 milligram per kilogram, again to keep things under good control. Now, phymatous change of the nose is nose, but it can be anywhere in the face actually, it's just normally the nose, is a little bit more difficult to treat. Well, it's a lot more difficult to treat. Now, phymatous change is whenever there is tissue hypertrophy, in other words, the tissue has got bigger. There are dilated follicles, so those follicles that are opening are now more baggy, and you can, the holes are bigger essentially. Often there can be filled with lots of sebaceous material that will come out like white little worms almost. And sometimes they have cysts within the follicles. Sometimes there's hard lumps where the cysts have calcified within the follicles. And then there's also these irregular nodular overgrowth, and it just distorts the normal anatomy of the skin. So you might then lose the shape of the nasal tip, the nasal ala, the nasal columella. Sometimes it's very, very distorted on one side compared to the other, and often it can just even lose the appearance that it was a nose. And the same thing can happen on the upper lip, the cheeks, the glabellar area, and on the chin. When this is first noted, it's very, very difficult to really say quite clearly what the best thing is to do, because the best approach is at the moment unknown, and we just have to go again with expert opinion rather than any huge big clinical study trying to show us what to do. However, in my practice and the experience that we get, and from you might see patients on the television series, what I do is I put them on to isotretinoin, and this is usually at a dose of around 0.3 milligrams per kilogram up to about 0.5, to try and induce a response within those sebaceous glands, to try and reduce the activity of them, and also the positive beneficial effect of taking isotretinoin on the extracellular skin matrix. So that's what I'll do. I'll put them on them, and I start to see a response at around about 12 weeks, and they typically will stay on this for about 9 months. As they're on that, I will also treat the kind of red component to it using a vascular laser, typically a pulsed dye laser, to treat any of the visible telangiectasia or the visible redness that goes alongside that phymatous change. And then only at the end of all of that will I then make a decision as to whether they do actually need to have some resurfacing of the nose. Now, by resurfacing, that's typically done with a carbon dioxide laser, or it can just be done with the blade or a coagulation approach. But it's where the nose is so big that it needs to be reshaped and pieces removed from it to restore the natural anatomy of the nose, and that is a physical thing that has to be done. So it's more like a surgical procedure with a laser or the blade actually. But I switch off the inflammatory component as much as I can as possible, and I'll tell you why that's important. If you were just to go ahead and try and reshape the nose using a carbon dioxide laser or other scarring methods, what can happen is that those inflamed follicles or deep cysts, well, they almost get a scar overlying the surface of them, and then that is that in itself starts to cause problems, because then there is no outlet to this very inflamed tissue underneath, and then that in itself can then cause further swelling. So number one is get the inflammatory component sorted out first, and then go on to the reshaping of whatever would need to be done with electrosurgery or dermabrasion or scalpel excision.